And welcome to the Dr. Bob Show. Do you have a little lump or a bump on your skin? Could it be on your forehead or your arm or your legs or anywhere on the body? It doesn't seem to be going away. It's got you worried. In fact, it may be getting bigger, and maybe you think it's just going to go away if I don't do something about it. We'll be talking about the most common skin cancer in the United States. 3.6 million people have basal cell carcinoma. That's a skin cancer, the most common, 3.6 million people. And there is new treatment that means you're not going to have surgery to have it cut out. So you don't need to worry about disfigurement with the new and the most modern treatment. My guest is Dr. Meredith Overholt. Dr. Meredith Overholt is a board-certified dermatologist. She takes care of skin lesions and basal cell carcinoma every single day, and she'll be answering our questions. I'm Dr. Robert Overholt. I'll be your host, and just like you, we'll both be learning about basal cell carcinoma. You'll want to stay tuned. We're talking with Dr. Meredith Overholt, board-certified skin specialist, dermatologist, and we're talking about basal cell cancers. Meredith, welcome to the Dr. Bob Show.
Thank you.
What is a basal cell cancer?
A basal cell cancer is the most common cancer there is. In fact, if you add up every cancer that you can name, colon cancer, lung cancer, breast cancer, all of the ones that you can think of, add up the number of each of those per year, you don't get the number of basal cell carcinomas. That common.
Wow, it's
Yes.
big time. Looking at it, 3.5 million people or more?
Absolutely, 8,000 diagnoses a day
A
in the
day.
United States.
So you see it all the time.
I see it all the time.
Do people recognize it?
Our patients get pretty good at it.
Uh-huh.
You know, unfortunately, once you've had one basal cell carcinoma, your risk of number 2 is at least 40%, and once you've had 2, your risk of number 3 is at least 80%. Now, these are not metastases, meaning they don't spread from one to the other, but the bottom line is if you had the right kind of skin and the right amount of sun to get one here, why not here? Okay.
So if you have one and you said, maybe it'll go away, you know, this and that, does it go away?
Typically not, although at first these will grow rather slowly, and occasionally will even outgrow their blood supply. So the middle may seem to die back. So many times basal cells will be described as being centrally ulcerated, and that's what's happening is the cancer is just outgrowing the amount of blood supply that was meant to be in that location.
Wow. So what does it look like on a patient's arm or his head? You know, where is it located?
Well, anywhere in the sun-exposed skin. You can get basal cell carcinoma in non-sun-exposed areas, and certainly if you've been in a tanning bed, then it's all pretty much been exposed. So you have to think about that, but most certainly are in sun-exposed skin. But that can even be in a part or in the crown of a scalp. You'd be amazed how many places do get sun that you don't really think that is getting sun. As far as what a basal cell looks like, they can have a wide variety of appearances. Anytime you have something that's that common, it's not always going to look the same.
So it can be different. So it's not necessarily hard and black and...
No, in fact, black would be more likely a melanoma. Okay, basal cell carcinomas are more often described as pink or pearly. Okay, and pearly comes from, I think the best way to describe it is think about a balloon when it's not blown up. It's sort of wrinkly and dull, but when you blow it up, it gets that luster. So that's sort of analogous to the tumor cells pressing against the outer layer of the skin and pulling it taut like that. When you stretch the skin, it'll oftentimes almost pop up and be more obvious and develop what's referred to as a rolled border.
Rolled
border.
border.
So those are classic. They can also have telangiectasias on the surface or dilated blood vessels that are visible to the eye.
So you've got some tips of the trade where you can pretty much say, uh-oh, that's what this is going to be. Does the patient come and say, I've had this for 4 months, 2 months? What do they tell you?
Oh gosh, it can be a variety. And some of it has to do with where it's located, because people might not know what's going on their back or on their posterior shoulder or something like that, might not be able to recognize that it's happening. And that's why it's great to have somebody to help you kind of watch your back.
Yeah, it is. So somebody else can look at your back, or can you know, girls, I see them combing their hair with mirrors in the back.
Sure.
Can they look at their skin pretty good from back?
Absolutely.
How often should you check your own skin?
As regularly as you can. It's certainly simple enough to do. I will say that people who watch their skin every day are actually less likely to see a lesion change. So sometimes it is better to stagger it out a little bit longer in between viewings so that you can really recognize that there has been a change that's occurred.
Do friends ever say, was that spot on your...
Oh, absolutely.
Yeah, and so that may be a way they come in.
Certainly.
So when you see one, who's prone to get that? Who's more likely to get that?
Yeah, well, certainly fair-skinned people who have spent a lot of time in the sun, and you know, certainly in our area we have plenty who fit that bill. But people who I do absolutely see basal cell carcinoma in darker skin types, especially if they've gotten a lot of chronic sun damage or been in a tanning bed.
So African Americans that have a dark-colored skin, it doesn't hide that sunburn, or it does a little bit, or they can get basal cell too?
They absolutely can, especially, you know, lighter skinned African Americans can for certainly get it. And interestingly, skin cancer on African Americans sometimes can present on the palms and soles, or even in the nail beds.
In the nail beds.
Being lighter colored areas. Now that's generally melanoma rather than non-melanoma skin cancer, but and squamous cell carcinoma absolutely can happen there.
So what do you tell patients to look for? Is it raised? Is it hard? Is it hurt?
Well, like I said, it's as often looks different from that typical description as it looks like it. So the key thing, I think, is what we refer to as the ugly duckling rule. Okay, and this was designed to help people pick up melanoma. Okay, and that's just watch for any lesion on your skin that looks unusual. Okay, if you spot a spot that you don't recognize, the first thing you want to do is an inventory. Kind of compare it around to the other spots you have, and if you do that and realize that you actually have 7 who look just like it, you're unlikely to have 7 identical melanomas, or 7 identical basal cell carcinomas. So, but if you see a spot that looks different from any others that you see, then you really want to pay attention to it and see what it's doing. And if it's growing or changing, that combination is known as the ugly duckling sign, something that looks unusual and that grows or changes. That needs to be checked.
Do you have to get a biopsy to make the diagnosis? How do you make the diagnosis?
Well, yes, if they are biopsy diagnoses, we certainly can. If you've seen enough, as many of them as I have in 25 years, you definitely have a good gestalt that that's what it is. But we do confirm that, and that's just because histologically or on pathology, there are actually several subtypes of basal cell carcinoma, and that can help you determine what the best way is to remove it with the least chance of it coming back.
What's the biopsy like?
Well, typically we just have to numb the area with a little bit of lidocaine, just cleansing the area, putting a small needle in, infiltrating it with a little bit of lidocaine. For a basal cell carcinoma, oftentimes it's a shave biopsy where you just take a little tiny portion with a blade. Occasionally we'll use a punch biopsy, which is a tool that looks somewhat like a little tiny cookie cutter.
And so you take a little
plug,
plug out and send that to the pathologist, and they tell you what it is.
Exactly.
So when it comes back basal cell cancer, how do you tell the patient? You say good news, bad news, or what do you say?
Well, we try to make sure that they understand that this is not deadly. Okay, it certainly needs to be treated, but not something that needs to keep them up at night. Okay, because basal cell carcinomas are destructive, and if they are allowed to progress, they don't metastasize to other locations. Well, technically they can, but it's very rare. But generally they will just sit there and get larger and larger and larger, and if they're allowed to do that, they can destroy a lot of healthy tissue.
Is there a new treatment, and that's what I want to get around to this show, and I want to spend some time on it because I think it's unbelievable what you can do now. What's a new treatment for basal cell cancer? What's it called?
Well, it's new and old. So sometimes we go back to the old. So one of the newest treatments is superficial radiation therapy for skin cancer.
Superficial radiation therapy, and that's what we're going to be talking about when we come back. SRT. You're going to be shocked at how good this is for me and you as we get that lump or bump on our skin. We're talking with Dr. Meredith Overholt, board-certified dermatologist, skin specialist, advanced treatment skin specialist, and we're going to be talking about SRT, superficial radiation therapy. And with that in mind, I always thought that basal cell cancer was, you surgically removed it, and that was the treatment.
Well, certainly that's the treatment for the vast majority of skin cancers, okay? Oftentimes they're small and very easy to treat. We can do it very quickly in the office. One of the most popular treatments is called curettage and electrodesiccation, where the tumor is simply numbed up, scraped off with a special tool, and the base is cauterized. It can be very quick and easy, and works very, very well in many cases. Others absolutely can be surgically removed. It depends upon the size, the type of basal cell carcinoma, and
you get the punch biopsy and you can tell what type it is.
right.
How deep
Some of
it
them
is.
are better about being kind of right where they look like they are, solid type. Others have more of a root or wispy border, and they can end up being a lot larger than they look like they are. Now that may not be a problem if it's in a location where you have a little extra skin, so you can just take a little
lot of
extra.
those places.
Yeah, but some places don't have a lot of extra skin, so surgery can be more difficult in that area and require reconstructive surgery afterwards. This has generally been the area where a Mohs surgeon has been very helpful.
Mohs surgeon. How do you spell Mohs?
M-O-H-S, which is named for a dermatologic surgeon, Frederick Mohs, many years ago at Mayo Clinic, who noticed that if he could take out a skin cancer and mark the edges as he went, he could just go back and take only tissue where he needed to. Freeze the tissue, check it right then, and go back and take additional layers. The advantage of that is that you're more certain that you've gotten the whole thing before you then do that reconstructive procedure to close it up. Well, they can take, honestly, this can take several hours depending upon how many layers they end up having to take and how complicated the reconstruction is.
So they keep shaving a little bit deeper and deeper until the pathologist says,
Well,
you got it on.
Mm-hmm. And actually the Mohs surgeon is the pathologist, so he's able to freeze the tissue, or she is able to freeze the tissue and look at it right then and make that decision.
So they've had a lot of training.
Very much so, yes.
From that standpoint. But now there is a new treatment. Tell me about SRT.
Okay. Well, everything old is new again. So radiation therapy for cancer has actually been around for over 100 years. Okay.
Wow,
long time. And the first cancers that were ever treated with radiation were skin cancers, which makes perfect sense when you think about it, because there were no CT scans and MRIs 100 years ago. So you couldn't tell where that prostate tumor was, or where that breast tumor was exactly, or where their brain tumor was. Okay, but with a skin cancer, you could watch it shrink and go away. Right. Okay, so radiation was a pretty commonly used treatment for basal cell carcinoma and other skin cancers.
Would it leave radiation scars?
It could, yes. The older forms could. And so it began to kind of lose favor towards even the mid-70s. You didn't see the instruments in people's offices quite as much. Surgical technique had really improved a lot and was having excellent outcomes. So radiation a little bit went by the wayside. But then, when you've got a cancer that is so common, there are going to be situations where surgery might not be your best choice. Okay, so into this void came a new form of radiation treatment called SRT. And SRT,
Again, what does SRT mean?
superficial radiation treatment.
Superficial radiation treatment.
So
Good.
this goes only about 6 millimeters deep into the skin. Yeah, pro and con, for that really bad, deeper skin cancer, this is not appropriate. So again, we need to make sure from the biopsy that we've got a tumor that's within that 6 millimeter range. Okay, but
good results with it?
But the advantage of being able to do a superficial radiation treatment is, many people will look at me funny like, radiation, that makes people sick, it makes them tired, it can damage surrounding tissues, and the answer is, in this case, no. Since it is so superficial, that sort of thing doesn't happen.
So walk me through it.
Okay. Well, again, once we've identified a skin cancer that is of the correct depth and in a location where there would be a distinct advantage of doing it by SRT. It's a hard location to reconstruct, for example, around the nose, around the ears, around the lips, on the eyelids, and in our office below the knee, down on the lower extremities where oftentimes the skin is quite tight. There's not a lot of extra room to take extra skins there. Exactly, and it's an area that doesn't get great circulation, so has a higher chance of infection or poor healing. Those are areas that are ideal for radiation therapy. Okay.
I have seen 2 friends that have had SRT from your office, and I really didn't know what it was. One was having a lesion right on the top of the head where they got a lot of sun, and the other patient was on their chin right here. So keep going.
Okay, yeah, so as you can tell, on the scalp, there's not a lot of extra skin to close your hole there either. So if you've got a decent sized area but fairly thin, SRT can be excellent there. So the real advantage is it's certainly it's non-surgical, and we do have patients who they just have a lot of anxiety about surgery. Just even numbing them up for a biopsy can be a process. They want to have anxiolytic medications to be able to go through surgery. So SRT is so much easier for them. Again, we have patients who have blood thinners. Okay, so they're worried about whether they might have, well, at least a lot of the bleeding. Sure. Many patients who have immune systems that are compromised. It's always possible after surgical removal of a skin cancer to have an infection. So SRT has an extremely low risk of infection occurring. So those are some of the main reasons.
And the patient likes it because you do it in the office?
It's like getting a dental x-ray. They come in, we map out exactly where the tumor is. A lead shield is created to protect the surrounding skin. The radiation cannula is put on the skin. The radiation therapist walks out of the room and hits a button. The radiation lasts for a few seconds. It's very, very much like getting a dental x-ray. There's absolutely no pain.
So when they come into the office and they get back in the room and you get ready, how long does it take the radiation?
They're there for just a few minutes. Now, that being said, you do have to come a lot of times. Okay.
And we're going to be talking about that. It fascinates me. So we've got SRT, superficial radiation therapy. It can be done in the office. It's essentially painless. It's like getting an x-ray. The patient loves it, but they've got to come in and get it. And it only takes, the people I've said, it only takes 3 or 4 minutes in the office. So with that in mind, we'll get the real facts when we come back.
Okay.
We're talking with Dr. Meredith Overholt, board-certified dermatologist, skin specialist. We're talking about the most common skin cancer, the most common cancer, the one, if you added up all the other cancers, there's still more basal cell cancers. Very, very common. Cancer is scary. New treatment, SRT, has amazed me. Now, Meredith, we were talking about how long the treatment is and what the patient has to do. In the office, how long does it take him?
Absolutely. The treatment sessions themselves are very quick. Like I said, it's almost like having a dental x-ray. It's so fast. Okay, so that's not really the problem. The problem is you do actually have to come a lot of times. I mean, in a way, that is the one way it is like regular radiation. You know, I know plenty of patients who've had 36 treatments for their prostate cancer, or they had 38 treatments for their breast cancer. So when they hear that it may require 20 treatments to do their skin cancer, they don't think of it as any big deal. Other patients think, oh my goodness, couldn't I just have that cut right out and avoid having to come so many times? But the reason that it's multiple sessions is so that you can give such small doses of radiation incrementally to build the effect that will finally kill the tumor, whereas you leave so much of the normal healthy skin alone, and that's how you end up with the nicer cosmetic outcome.
So it looks better. It's essentially painless. You come there, it's a short period of time. What does the patient tell you? Do they say, oh, this is the best thing I've ever done? Or, you know, I wish I'd have had cut out.
Well, we like to really select patients carefully. This is absolutely not the treatment for every basal cell carcinoma by any stretch of the imagination. But when we have a person who really values the fact that they have a good cosmetic outcome, you know, we have such active patients, and if you have a skin cancer on the back of your right hand and you're a golfer, or you do a lot of activities with your hand, and you would have to have that, you know, stitched and bandaged and really have that hand out of commission for a period of time. With SRT, that's not the case. One of my favorite patients for SRT was a patient who had 2 squamous cell carcinomas on the back of his hand. They were large but thin, and you know, if you took enough skin to remove one, you'd have nothing left for the other. So he was talking about perhaps doing 2 grafts. It was going to be a major reconstruction. This gentleman was left-handed and was taking care of his wife who has Alzheimer's. So he would just come in, have those 2 treatments. He could go back out and do everything he needed to do the entire time with no bandage, no care. Perfect.
Whoa. So can they come in at lunchtime, get it and go?
Absolutely.
Most of them come in at what time of day?
Any time of the day, you know.
Depends on the person.
Yeah, it depends upon the person, what's convenient for them. We do try to make it as quick and easy as possible.
How do they prepare? Let's say you got it on the top of the head. You know, I've had a lot of sunburn on the top of my head. So if I had to have SRT on the top of my head, how would I prepare myself when I walked into your office?
Not at all. That's all done for you. We have a certified radiation therapist who does the treatment for you. So you just do what Maury tells you in my office.
And I'll say, yes,
very,
ma'am.
very easy, yes.
Yeah. Does it hurt me? Would I say ouch, or I just say,
no,
gosh?
You know, the first 10 treatments, it almost feels like you've bought the emperor's new clothes because nothing seems to be happening. But by about the 10th treatment, a pink circle will develop around the tumor, and for the rest of the 10 treatments, you know, it'll get progressively pinker and pinker. We do get some people who complain about a little bit of tenderness, but it's not very often that people really think that it's something that bothers them exceptionally.
The 2 people that I have seen that have had SRT have said, wow, because it just doesn't hurt them, and they say, I would do that again 1,000,000 times. But it's a new advancement. Is there any other new things in the future that probably are going to even be better than SRT?
Oh, I mean, always could be, but I do think that the new forms of radiation are here to stay. I've actually been contacted by 2 additional companies doing 2 different types of radiation that are going to bring them into doctors' offices. So I do think that this is, you know, a change that is here to stay, and insurance companies seem to be fine with it. You know, Medicare definitely pays for it. I think we have all but one of our general insurance companies who seem to pay for it without a problem, as long as we kind of can convince them that this is the right treatment for this individual.
You don't have to go in the hospital. You don't have to get anesthesia. It just takes away all of that. It's now And more things are being done in the office,
Right.
thinking of the patient and what can be best for
Right, and we
them.
did mention, a lot of people are worried about taking pain medication. They've had trouble with pain medication in the past,
Yeah.
or they just or know people who have. They don't want to take any true narcotic pain medication as a painkiller, and certainly SRT, we've not had anybody that's gotten anywhere close to wanting that.
Meredith, you're an amazing teacher.
Thank you.
Learned a whole lot, and I knew I was going to learn a whole lot today on SRT. That's all the time that we have for this show, but we want to be sure that we tell people, remember, number one, exercise. Be sure you're exercising regular. Make it 40 minutes every day. That means get your tennis shoes and go out for a nice walk with somebody and enjoy that time of your life. Be sure that you're eating properly, more fruits and more fibers. So start that day off with breakfast, fruits and fibers, and have the same basic foods, no fried fatty foods later on in the day. 7.5 hours sleep. If you're not getting enough sleep, you should be. 7.5 hours is what the average length of time is. When you get 7.5 hours sleep, you'll feel fresh, you'll be happier, you'll not word search, the people around you will be happier, and you'll be happier. And the most of all, what is it that we want in that Dr. Bob Show? It's laughter in your life. Be sure that you're taking the time out to laugh, because remember, the more you laugh, the more you giggle, the healthier you're going to be.